Good morning. I am Dr. Neeta Singla. I'm from National Institute of TB and Respiratory Disease. And I head the Department of Epidemiology there. So I'm not a microbiologist. And all my people around me are microbiologists. So I'm the odd man out, maybe, but I'll try to balance it. So on my left is Dr. Manpreet Bhalla. She is the head of the Department Microbiology at NITRD Delhi, and she is also the director of the institute right now. And the NITRD is a WHO Center for Excellence, and it is also a NABL accredited national reference lab for TB. And she has more than 30 years of experience. So welcome, ma'am. We have Dr. Joy Sarojini Michael. She's a distinguished clinical microbiologist with over 22 years of expertise in mycobacteriology, and she has been in CMC Vellore, and now currently she is working with Gates Foundation. We have Dr. Sarabjit. Dr. Sarabjit is the Regional Technical Director for India and Southeast Asia region at FIND. And additionally, he has been elected as the chair of the coordinating group of the Global Drug Resistant TB Initiative. So, very warm welcome, Dr. Sarabjit. We have with us Dr. Prabha Desikan. Hello, ma'am. Dr. Prabha Desikan is Director Professor and Microbiologist at ICMR BMHRC Bhopal. And she's also served as the director, and she's looking after the national, she's set up the National Reference Lab catering to different states. We also have with us Dr. Phurpa Tenzin. He has come all the way from Bhutan, and he's the program manager for the National TB Control Program, Communicable Diseases Division in Department of Public Health, Ministry of Health, in Royal Government of Bhutan. Welcome, sir. So that's either Dr. Hanna. Sorry, Dr. Hanna. Dr. Luke Elizabeth Hanna is a scientist F in and heads the Department of Virology and Biotechnology at National Institute of Research and in Tuberculosis at Chennai, and she specializes in immunology, and she has a large TB biorepository at her center, and she's looking after that center. So, starting our panel discussion, as we all know, India has the most significant progress in TB control, but early and accurate diagnosis still remains a critical challenge. While innovations in molecular diagnostics, AI based tools, and rapid tests are promising, their real impact depends on effective funding, streamlining regulatory pathways, and successful implementation in our public health program. So we have a very esteemed panel with us, which is representing the government agencies, the funding agencies, and the regulatory agencies. And they will help us to explore how we can accelerate the R&D and overcome the implementation issues that come up with us. So first of all, I would like to ask Dr. Hanna who about the innovation and gaps in TB diagnostics. So, what are the key gaps in TB diagnostics in India that need urgent attention? And how can we foster homegrown innovations, including AI driven and molecular diagnostics?
Hello to all. So we've been dwelling a lot about this question in the last 2 days, yesterday and today. So my response will be a summary of what we have been hearing about, how to address the diagnostic gap and cover the missing millions. So the I will just group the responses under three categories. One is that there is limited access to high quality diagnostics, particularly in the rural areas. In the urban laboratories, there is access to advanced molecular diagnostic tests, but in the rural and suburban areas where most of the country's population resides, there is still limited access to all these high end tests. And this coverage needs to be improved in order to address the missing millions. The second is the lack of tests which are sensitive for specific populations. So we just heard in the previous discussion about inadequate tests for pediatric TB. So we need more sensitive biomarker-based non-sputum tests which can be used for diagnosing TB in the population of children, particularly particularly children less than 5 years of age. We also have such other populations, such as immunocompromised individuals, people with living with HIV, and also extrapulmonary TB, where we need more sensitive tests for diagnosis. And thirdly, the gap is in underutilization of the novel, innovative technologies like AI and data driven technologies, which are still underutilized in our population. So these become very useful, like screening the X-ray images. And also integrating the data from the country is going to help in early detection and improve diagnosis and earlier linkage to care. So, put together, we need a comprehensive approach where we need strengthening of infrastructure in the peripheral laboratories, training of the personnel there to administer or undertake advanced tests, and also develop more sensitive tests that can be useful for special populations that we looked at, and also the receptiveness to adopt the innovative technologies that are coming up in terms of AI and data driven methodologies. So, this is going to play a big role in identifying the missing millions and linking them to care. Mm.
The second question was how can we foster the homegrown innovations?
Okay. So this again requires a multifaceted approach, as you will all agree. So we need to create a supportive environment for the development, deployment of novel diagnostics in order to fast track this process. And secondly, we need to encourage the development of point of care biomarker tests, which can work with non-respiratory specimens, which can be useful for populations where we still are lacking sensitive tests for TB diagnosis. And thirdly, obviously, come up with more innovative technologies and methodologies and an open receptive platform to integrate them into the country's program so that they become available for public use. And finally, a process of incentivization where we can offer subsidies or low cost licensing for companies which are developing such diagnostics, so that they are able to develop low cost affordable diagnostics which become available across the country to cover the entire population.
Thank you, ma'am. So, like ma'am said, that there are gaps, and more things need to come up. So, my question is to Dr. Prabha Desikan, who's from ICMR Bhopal. What are the key challenges in the diagnostic research that people face, and what are the regulatory requirements for these diagnostics tests?
Right. Um, the thing about the challenges with diagnostics research, as we've been hearing in the lectures also yesterday and today as well, I would think the primary challenge is to get an adequate sample size to conduct a study. Now, the issues that you face with collecting an adequate sample size is the patient has to give you two samples just for diagnosis, and then to expect the patient to give you more samples for a research study, which is not really going to benefit him in the short term, that becomes very difficult. The patient has to come losing a day's wages each time he visits a healthcare facility. And even if he makes the effort to come, um, it is very difficult for him to for us to retain him to manage to go through the study protocol the same way as we had planned it. If the researcher would prefer to go to the site itself, to the patient's home, to obviate this issue, then what happens is there is the stigma to deal with. The patient doesn't want his neighbors to know that he has tuberculosis. That apart, many of the breadwinners are not available at home during the daytime. They would come back late at night. Many times, some of them are in a drunken stupor. So that raises security and logistics issues for the researchers itself to collect samples. And then comes the diversity itself, the entire diversity across our country. For us to plan a specific, design a specific protocol and implement it across the various regions in our country is also a challenge, because we are just so diverse in terms of language, in terms of dialects, in terms of geography, in terms of physical accessibility to vulnerable populations. Many of the vulnerable populations are in mountainous regions, which are very difficult to reach. There are no roads to go there, but these are the pockets that actually would give you results that are translatable into policy, into an innovation, into a lot of things. Then you have the HIV, TB co-infection pandemic. So when with HIV, TB co-infection, the production of sputum becomes less. You can't get a sputum sample. To get such patients to also participate in a study like this would be very difficult, because they are already exhausted with the co-infection. They are also exhausted with the regimen that they have to take, and to encourage them and motivate them to participate in your study requires a lot of expertise, a lot of patience, and a lot of time on the part of the researcher, presuming that he knows the language that they speak in. And of course, what we all face are the regulatory issues. I wouldn't call them challenges. They are required to streamline, to make sure that processes are ethically conducted. The number of regulatory the number of regulations that we would actually have to go through as far as innovators are concerned. An innovator would require to approach the CDSCO for the initial registration for making a diagnostic. Would also require to get a license to test the diagnostic initially. Once he's tested the diagnostic, there is this entire process of performance evaluation. Number of laboratories that the CDSCO has already defined on their website. But if the innovator wants to get into the program, then it has to be through the ICMR pathway, where the innovator would have to reach out to ICMR. ICMR will coordinate with CDSCO to find out whether this is an innovation that can be taken into the program, after which the ICMR has its own guidelines for technology development cooperation with innovators. That covers not only the field studies and the clinical studies, that also covers the IP rights, the data protection, the branding, the acknowledgement. All that also is covered by the ICMR guidelines. And then there are the institutional regulations. You need to put it through the institutional ethics committee, make sure that you have an ethics committee approval. And of course, the big bugbear is the informed consent, where you would have to translate it into the local language itself and then translate it back to English to make sure that you have translated it properly. So these are various levels of regulations that would need to be followed. And CDSCO also conducts post-approval surveillance, post-marketing surveillance, to make sure that all its regulations have been complied with. So all these regulations need to be addressed.
So, ma'am, you've very well, enumerated the challenges that come into not only sample collection, but all of us who have done a research, we know when we have to submit a research, it takes, I don't know how many number of forms we fill to do a research. It takes us, 2-3 months to compile all the documents. We submit it, and then there always some issue that comes up. Again, you submit and there have been so many studies, at least in field, that we see that we submit to ICMR and they are stuck somewhere or the other with some issues, and they actually never take off. there have been so many studies. So there are a lot of challenges. Thank you for enumerating. Coming to you, Dr. Manpreet ma'am, there are many innovations which overcome this diagnostic struggle, and they transit from research to the real world use. So, can you tell us what are the key barriers in scaling up these new TB diagnostics, and how can we overcome them?
Yeah. So thank you, Dr. Neeta. And as you rightly said, that there's a lot of gap between the after the research and for these technologies to come into the market use. As Dr. Prabha has said, there are various many barriers. So the first key barriers are the regulatory and policy barriers, which Dr. Prabha has already told about. But I just like to say again, because this leads to that. This is one of the reasons for the delay. And also, we need to develop specific protocols before we start a study. Like most of the ICMR studies are multi-centric. So first of all, the protocol has to be developed so that the same SOPs can be followed at all the sites. And for this, again, it takes a lot of time. All the sites have to be coordinate with each other. We make a protocol again for the sample size. Sample size is very important. So what is the actual sample size which will give a relevant result at the end of the validation study. We should have the data whether it is the test is sensitive, specific, whether it is fit to be used in the market or in the program. So for that, that takes time. And again, as madam said, for taking the ethical approvals and consent from the patient. So for this, we can what we are doing right now, we are using the prospective samples, we take a consent. But if we have a biorepository or a biobanking, so we already have well characterized samples with us. We have the clinical history, we have the demographic data of the patients available with us, and we have already the results of the, like usually when we do these validation studies, we do the comparative with either existing molecular techniques like CVNAT, TrueNAT, LPA, and the culture. So if we have a biorepository in which we already have the results of all these tests available with us, then we can directly go for the index test and just do the index test and with the same sample, stored sample, and compare the results with the available data. So that will shorten the time. Then secondly, putting these new technologies in the already existing systems, where how to go about it, how to plan that. Also, there has to be a coordination between ICMR and the government, CTD, the state government also. So usually, after the validation is done, like we have completed, we are told that this also should have been done, or like the field studies also should have been done. So I think there should be discussions and coordination with all the stakeholders, as well as the innovators should be told exactly that what type of test is required by us. And then we should go about it planning upfront only, do the field studies as well as the other studies, validation studies at the tertiary centers. So for that also we need to have a developed protocol to go about it. Then coordination, I already told you, and based on the requirements, like program C, we need to say what type of test we require. Do we require a test only for the detection as a screening test, or we need to have upfront resistance also detection, like for at least for rifampicin, INH, and FQ resistance. So that also should have be done initially only. As per my thing, we should do simultaneously for detection as well as for the drug resistance. Sometimes what we do is we do just do the test for the detection, we validate that, and then again as a second step we go for the drug resistance testing. So it should be done simultaneously. So that will shorten the delays. Also, the innovators have to be told again, we have to see at what level we need to place that test in the algorithm, or suppose we need to place it at a tertiary care center, or at the district level, or at the IRL level. So that depending on that, the innovator has to develop the test, whether it has to be a point of care test, which has to be, it should be battery operated, it is very simple steps are involved, which can be done at the peripheral level, or if it is at a tertiary level, we can have a little higher complexity tests, and the technicians need to be trained. So different levels of training are to be done. So depending on the scalability, we need to address these tests. And so overall, I would just like to say that we can overcome all these things by having a coordination initially itself with all the stakeholders, the government, and as well as the researchers, and so that we come up with a test which is feasible and suitable, and it can be included in the already available algorithm, because we cannot displace the people who are already doing this test in the program. So they get confused that we are doing CBNet, we are doing TrueNet, and where should we place, when should we do this test, replace it for smear microscopy, or replace it as a in place of NAT. So that should be decided initially, so that we can reduce the time.
Thank you, Dr. Manpreet. So, as you said, funding, the scaling up takes lot of effort, not only in part of innovation, but also funding is required. So, in that context, I will come to Dr. Joy, who is with Gates Foundation working. So, just wanted to know, ma'am, what are the key funding sources and challenges for the TB diagnostics R&D in India? How can public private partnership improve the funding access? And beyond funding, what resources gap exist? How can we enhance technical support to R&D?
Thank you, Dr. Neeta. I think it's a challenge to change hats as a microbiologist and then now in Gates Foundation. But I think my task is made easy by this conference. This where you've heard yesterday about a lot of sessions from both the government as well as NGOs and various funding partners who were there yesterday. So, as you all know, what you have to have in mind is there are both in government in India as well as abroad international funding agencies that are there. So, in India, you heard about ICMR talking yesterday about ICMR and MedMitra, MedTech Mitra, DBT, and BIRAC. We have NGOs like from Tata Trust, we have the Tata India Health Fund. And there are other funding agencies like Gates, Union, USAID, and NIH. Yeah, it's a question, but there are lots. So you have to look at various calls, various proposals that come out in their websites, and as innovators and researchers, you can modify, or you can modify your search according to what you want. So the various groups, like some look at the field studies, some look at innovation, some look at enhancing support. So you need to look at areas where what you want, and accordingly go to these various groups, and like global World Bank and various other agencies that were talking yesterday, who have Global Fund and even WHO Fund. You can look at their websites, and the proposals and calls will come out, and then you can apply accordingly. But this in this program also, what we're trying to do is we're going to try and help innovators to go through the right pathway, where to apply for funds, and how to help you will also be feedback will be given to you based on what we are all going and observing and helping you. So definitely you will get help in that way, in advisory role from us. Private, and then in addition to these funding agencies, there are private sector pharmaceuticals, biotechnology companies that play a very important role in TB R&D both in India and abroad. And so you can partner with such companies, and like we saw a lot of examples of startups who are working with other larger companies in India, who are helping them with resources, with technology, how to make it into your production, into larger production. So there are a lot of sources now made available. Now it's going to be following this conference, this meeting, we are going to summit, we're going to put it out there, and how we can all help you. But the major gaps that is happening is, even though these are all there in India, it's never enough, because because the problem of TB is so high. So I think we all need to work together, and not only help the innovators, both as funding agencies and researchers, to provide samples, to help them have continuous funding, because these funding comes only for certain areas. So in the later stage of clinical validation or device lock, technology, you want to design lock and then you want to manufacture, where will they go for funding? So I think we should look at various areas to make sure that we can continue. Yes, government has come up with a lot of programs now to increase funding, both ICMR and DBT and NTP, Niti Aayog. We heard from everybody yesterday. So the future looks good, and we need more inputs and more help to, help all the innovators that are there. About private public partnership, I think there are already centers like innovators and accelerators and incubators that can help startups, that can foster, mentor, and give funding, and provide critical, capital funding needed to start. So there are systems that are already there. So I think a lot of guidance that needs to be given to the innovators to how to go about, and things are just falling in place only now. It's coming out in black and white, and so it will be definitely beneficial to many of the innovators who are here. In addition to that, there are specific areas that, as both government and international agencies need to help all these innovators in the form of technical support, how to simplify sample processing or improving the yield, how to improve sensitivity, specificity, make more near POC or POC tests or screening tests, whichever that is our priority, the country's priority. Simplify PCR steps, especially, as simple as it is, minimize DNA extraction, simplify everything PCR, then it's, easy acceptability in the community about, using AC versus, non-AC instrument that can run on battery, etc., or use sputum versus non-sputum samples, like tongue swab, for screen, those are more useful. So we have to help innovators to come up and develop those areas. And there are specific grants that are coming out. If you look recently, Gates had come out with specific areas to simplify testing strategies, sample strategies, testing paper-based methods. So there are a lot of innovations that can be done, which is already here, and specific for those goals, you can go and get funding from. Thank you.
Thank you, Dr. Joy. It's nice to listen saying when you say that the future looks bright because funding is not an issue with you, because with USAID pulling out of many projects, it's been a difficult situation. But that's good to hear. So coming to Dr. Sarabjit, as so many innovations are not now coming up. So what are the emerging technologies that are shaping the future of TB diagnostic, especially the point of care test and multi-disease platforms that are coming up, and which innovations holds the most promising thing for in next 5 to 10 years?
Uh, Thank you, Dr. Neeta. Before I start, I'll take you a little back in time. This was 2005-6, and the program had just started to roll out the programmatic management of drug-resistant TB program, which we initially called as DOTS Plus. I think a lot of people in this room were there, and we were all working together in rolling this out. And at that time, the only technology available was the solid culture in DST, the Lowenstein Jensen medium, and the samples, which used to be sent from these patients, and they were all very critically ill, failures of category 1 or category 2 regimens, contacts of MDR-TB. The results used to come after 4 months. 50% of the patients would have either died or were lost to follow. It was really pathetic. Then came the line probe assay, which got endorsed by WHO. This was around 2007-8, and program took a major decision of implementing line probe assay, which was a game changer. 2010, we had another big landmark with the Gene Expert coming in. However, it's been 15 years since Gene Expert, and then subsequently the other low complexity NATs coming in. The situation is still very grim, and I think the World TB report clearly alludes, that less than 50% of the patients are still getting a molecular test as an upfront test. That's the current situation. The future looks much more optimistic because we have seen the challenges with, large scale implementation of the available NAT technologies. It is both the cost, the infrastructure requirement, the training needs. Now, when I compare, if we were using or we are still using smear microscopy as an upfront test in most of the cases, now the available or the emerging technologies are more point of care molecular tests, which are either equipment free, and some of these are in early stages, some of these are in late stages of development, and some of them are actually going under validation. The second is more point of care molecular diagnostics, and while I give some examples, it is not that these are the only technologies or only brands available. For example, Lumera, Lucera, there are several technologies which are in late stage of development or under validation. The third, and I think before I go to this technology, is that we have also realized from our experience that TB is not a static disease. It is actually a spectrum, starting from incipient TB and then subclinical TB infection and then subclinical TB and then a full-blown TB disease, and then within the TB disease, the various forms of drug resistance. And for each of these, you need diagnostic tests, because the earlier you are able to pick up, if you're able to pick up TB infection and we are able to give a effective treatment, we will reduce the breakdown significantly. We will cut the transmission chain. If we are able to pick up subclinical TB, the transmission will again get cut. This was, this kind of evidence or data was not available earlier. We are still, if I go to subclinical TB currently, our only way we can screen subclinical TB is using imaging based X-rays, basically. And now we get it complemented. These are complemented with the AI enabled chest X-rays, which have improved its effectiveness and efficiency. But getting an X-ray, even if it is ultra portable, still remains a challenge. One, because of cost, and two, because of the logistics. There are now several technologies which are either validated or under validation, like the cough apps, which even a patient could actually do it themselves. And these would actually help screen or detect more TB patients. The fourth, the pipeline is related to the sequencing. So earlier, we were just reliant on liquid cultures and solid cultures, and then came the WGS, which was whole genome sequencing, where you were sequencing the entire TB mycobacterium. But now with targeted NGS coming in and WHO having recommended it last year, we are able to pick up some specific mutations which have a clinical relevance. We had huge platforms. I remember when WGS came in, we had 6 centers of excellence which Find supported. We gave them these big machines, Illumina machines. Now, if I look at it, we have Oxford Nanopore, almost like handheld technologies. And now the next generation are actually plug and play. These are actually reducing the costs. These are reducing the turnaround time. And these are also making sure that these technologies are more decentralized as earlier. So this is what the pipeline looks like. But having said that, what I will, kind of underscore this whole thing is that there is a place for every technology. It depends on what kind of strategy you are using. So just to give you an example, most of these technologies that are coming in are also multiplex, one in two sense. One is they are not just relying on testing sputum. They are also compatible with alternate samples like tongue swabs, oral swabs, maybe urine, maybe blood. There are some technologies, which have shown very promising results with blood. I think TB is the only disease where we do not have a blood test still available. It's available for every other disease. Then we have the strategy. And in the strategy, and plus, when I say multiplex, the second part was that they can be used for multiple pathogens and not just TB. So HIV, hepatitis C, human papilloma virus, MRSA, pneumonias, these technologies can be used for those pathogens as well. if you are able to use a low sensitive test at a much larger scale in the community, studies have shown that you are able to detect more cases, rather than relying on a very highly sensitive or a highly specific test. So each of these tests will have a place. If you are using an active case finding approach, you need a screening test, with which you can test the oral swabs or tongue swabs, which can be easily collected, or urine, the lipoarabinomannan, which is currently the only antigen based test that we have. Biomarkers, we really do not have a lot of tests, in TB. I'll say hardly any tests in TB which are using biomarker technology. And then, as you develop these tests, you will then come into those lateral flow assays, which can actually be done at the community level. So I'll just end by saying that the pipeline is robust. There are a lot of technologies that are coming in. There is, and I think it's never been so robust, in the past. So for the last 5 years, we've seen that. And if you read the TAG pipeline report for 2024, it has actually 3 pages full of the technologies which are at early, late, or validation stage. For last few years, and I was just going through those reports, it was just a handful. So promising times, but what we need is strategies to how we quickly validate these tests and use them as per the country context.
Thank you, Dr. Sarabjit. We also have National Program Manager from Bhutan. So, sir, I would like to know that how can a new diagnostic be integrated into the TB screening and TB program?
Thank you, Dr. Neeta, for giving opportunity to Bhutan to share how we can integrate our TB screening and treatment in our existing system. Firstly, as mentioned by the earlier speaker, of course, we could see that there are a lot of innovations coming on in terms of the diagnostics. As per our national policies, it should undergo our policy alignment and health system strengthening, including the capacity building of the health workers, where there is requirement of the multi-stakeholder involvement. Wherever there is a newer diagnostics coming up, we need to first revise our national guidelines to incorporate all those new diagnostic. And secondly, it should undergo our regulatory approval process, which involves validation processes. And then lastly, we need to have our capacity of our health workers to use those new tools, and also the infrastructure set up to implement these new tools. In terms of looking at the new diagnostic tools that which we will be very promising, and then has a very good capacity implementation in terms of programmatic level, is that we could see the new diagnostic tools for screening like Hanna X-rays, which is portable and it can be taken to our periphery health centers. And secondly, it can be used to reach the unreached populations and also those vulnerable and high-risk groups. Additionally, these handheld X-rays with the use of AI will also give accurate readings, where it will have impact on the HR, where we won't use the radiographer to reach these readings. So this will also enable us to give the presumptive TB cases. Once we identify all those presumptive TB cases in those unreached populations, in these like high risk populations, and we will subject these patients, these presumptive TB cases, to the newer diagnostic tools, especially with the use of molecular rapid diagnostic tools like expert machines, TrueNets, etc. These machines give us the accurate readings, accurate results with more sensitivity and specificity, which ultimately will give our treating physicians or health worker professionals to give the right choice of regimen for the patients, and then accordingly we will give them whether it is longer regimen, shorter regimen, or whether it is whether it is first line drugs or second line drugs. ultimately this will boil down to the quality of care of the patient, and then it will improve the life of the patients.
Thank you. I fully understand it's very challenging for a national program manager where to place a test and how to use it in your program. So my last question is to you, Dr. Manpreet. How can R&D align with the global TB elimination goals?
Yes, so this is a very important aspect. If we want to eliminate TB, we have to align R&D with the elimination to what if we want to accelerate TB elimination. So I will just highlight a few points which will lead to this. The first thing is improving early diagnosis. So for this, we need a test which is rapid, which has the speed and sensitivity of the test should be good. It should be a point of care diagnosis which can be used for resource limited communities. Secondly, we should target the vulnerable populations, as has already been told by earlier speakers, that we need to target the children, the HIV population, and elderly. And there should be a universal screening test, like a single test which can detect the active TB as well as latent TB. So that will be the ideal test, which so that we can find out at the earliest. Again, we need to have a test which tells us about the drug resistance TB at the upfront, as I already told you earlier. So that will also help for eliminating, and integration with the digital health systems. So we should go ahead with the technologies like artificial intelligence based technologies, then data analytics and machine learning. So all this should be incorporated into the new tests. Then the most important thing is affordability and accessibility. Obviously, the cost of the test should be sustainable. Like for our low and middle income countries, the test it should be of low cost and it should be easily accessible in the remote areas. So these are the points which will lead to the elimination and R&D.
Thank you, Dr. Manpreet. So before I conclude this session, I want to have a small rapid fire round to get the things which ICMR wants from us. Dr. Hanna, what are the 2 priority areas for diagnostic research for NTP?
One thing, as we have heard, to identify and accelerate the development of highly sensitive next generation tests, which are based on maybe biomarkers or molecular tests, particularly helpful for identifying TB in challenging populations, such as we have heard in children, as well as in the immunocompromised individuals, subclinical TB, extrapulmonary TB, where we do not have sufficiently sensitive tests at the moment. And secondly, to encourage the development of a simple home-based test which can be self-administered, to increase testing accessibility. This will help people overcome the barrier of visiting clinical centers for diagnosis. This can encourage early detection and linkage to care.
Thank you. Dr. Prabha, what will be the 2 impactful programmatic innovations related to diagnosis which are based on evidence?
Oh, I think one would easily be the molecular diagnostic tests that were based on evidence, the low complexity assays that are very near point of care, the TrueNat, the Gene Expert, all these molecular tests, they have increased the accessibility to the test, and they've also reduced the turnaround times and also a presumptive diagnosis, which is what you want. And now we're using them upfront to replace smear microscopy. So I think that would be easily the most impactful innovation that has come over the past few years. The other I would definitely say is the AI solutions for computed X-rays. Many times we are faced with situations where the patient is not able to produce adequate sputum for a diagnostic, and that is where these digital X-rays, and if there are handheld X-rays, all the more better, because accessibility increases with that. And if you have AI solutions are actually the way to go now, because you really don't have specialized radiology solutions, or a radiographer. Radiographer, yes, but a radiologist to give you an analysis on the X-ray. So I would say these two are the most impactful.
Dr. Joy, diagnostic research needs to support the goal of TB elimination.
I think Dr. Hanna has talked about vulnerable population, EPTB children, but I'd like some research to be done on subclinical TB. So that, for TB elimination, not only active TB, but subclinical and definitely latent TB. So these are two areas that are not looked at currently. More emphasis is on active. Yes, definitely I'd love in children and extrapulmonary, but latent and subclinical is something that we need to work on.
Thank you. Dr. Sarabjit, two diagnostic technologies in the pipeline which you would suggest to take forward?
So I, and I think Dr. Anna's already alluded to it. My wish list actually is having a self-test. A self-test which works as well on sputum, non-sputum, and is able to give you, if not a confirmation, but at least with a high negative predictive value, that it rules out TB in the general population. That's one. Two, integrated or multiplex technologies, because let us go back to our basics, that whatever patient that you are testing, considering that might be presumptive TB, only 10% of them would actually turn out to be TB. 90% of them have some other disease. So if we are collecting sputum, or we are collecting oral swabs, or we are doing testing in this patient, can this multiplex platform help diagnose this case? Because we have to treat a person, we are not treating a disease.
Right. Thank you, Dr. Sarabjit. And Dr. Manpreet, two wishes that you want that should come into National TB program.
Yeah. So my first wish list, as Dr. Sarabjit has said, like I would want to have a lateral flow assay point of care test, like which can be done by the person, as already said by others also, Hanna. It can be a self test which is done, like it for COVID we did a antigen testing test, and so that and it can be done on other samples, like not only sputum, urine sample or blood sample or oral swab or tongue swabs, which can be done on this test, this platform. And second, my wish list is that for development of new vaccines. And I think some incentives should be given to innovators for coming up with for development of vaccines as well as new drugs, because I think slowly we'll be developing resistance to the new drugs. So I would like that we come up with new vaccines and new drugs development.
Thank you, Dr. Manpreet. And sir, would you like to add something for Bhutan?
Again, I would like to thank Dr. Neeta. As you know, Bhutan is a resource constant country. Given an availability of the adequate resources, definitely I would like to join earlier speakers that our wish in the future would be expanding these point of care technologies, especially the rapid molecular diagnostics at the peripheral health centers, especially at the primary healthcare level. And second point that we would like to implement at the national like programmatic level is that we would like to link these new diagnostic tools with our digital health and surveillance systems for real-time reporting, patient tracking, and also for the monitoring of the TB patients for better treatment outcomes. Thank you.
Thank you, sir. She's been telling me not to say anything further, so I cannot ask any questions from the audience. But thank you, panelists. We understand that there are challenges in the research, but the efforts have to go on. So thank you so much for being here, and thank you.
Please present the token of appreciation to all our experts.
Picture.